we want to welcome everybody to this very fascinating topic of integrative dental medicine, which we'll explain exactly what that means. But Laura Hooper and myself are so happy to be involved and hopefully contributing to the community at Pankey. And so we want to talk about our passion, which is what we believe is the next great frontier in dentistry. I've been very blessed. My first exposure to the Pankey Institute was in 1982. I came down for a course that summer after joining the practice of Dr. Pete Dawson, who, as you may know, has been very involved with Pankey for many, many years and was a dear friend with Dr. Pankey. We miss both of them so much, but I was blessed to be mentored by Pete and by Dr. Pankey and men like Bill Lockhart and David Hildebrand and Erwin Becker, who impacted my life in ways that I could never, ever express my gratitude. The course it set me on, both professionally and personally. And in fact, it has a lot to do with what we're going to be talking about tonight, because all of these men stimulated us to be the best we could be and to keep looking for more answers and how we can elevate our profession to be better than we ever thought of, and to find new ways to help our patients and to do things that will continue to change the lives of our patients for the better. And so just a thank you to them. I want to give you a little introduction to myself and Laura, because some of you don't know us. I am on the visiting faculty at the Institute and have been on and off on the faculty since about 1985. I'm the founder and CEO of IDM Scholar Society, senior faculty at the Dawson Academy, work with the University of Florida College of Dentistry, and have been very involved in the American Equilibration Society, AES, of which many Pankey alumni are part of AES, as well as the American Academy for Oral Systemic Health, which we call AOSH. And that's where I met Laura and began to learn about her work that you'll learn much more about tonight. I've also written a book about what we're talking about tonight. I've called it The Shift, meaning the paradigm shift, the dramatic movement toward health-centered dentistry. So it's about looking at dentistry not as tooth carpenters, but as oral physicians that are specialists in oral medicine. And yet that's only part of the whole body, isn't it? So we need to know about the whole person that we're helping. I also want to introduce for the first time to the Pankey family and community, Laura Hooper. Laura is an amazing hygienist, just one of the most brilliant people I know, who has pursued excellence to the highest degree. She's from Columbus, Ohio, graduate of Ohio State University, where she was an ice skater there. And you can see some of her background. Laura, why don't you just say hi and tell us a little bit about yourself before we jump into the webinar?
Yes, thank you for that introduction. And I think the most profound thing I want to share about my background is that I'm one of the first hygienists in our nation in the United States to actually work for a cardiologist and a dentist. So I was part of initiating that team early on. And then I currently now work for, as you see there, the Prevent Clinic as a care coordinator for Dr. Gina Pritchard. So I have the unique perspective of being a hygienist, chairside actually working for MDs. And I feel that is important to know in my background when I come to the table looking at cases that, right, I have a different perspective working both for a cardiologist and now that nurse practitioner. So, of course, anyone out there, OH, I hope I get some IOs in the chat. Go Bucks, they're doing well this year. So I'm also a huge Buckeye fan.
Well, thank you for joining us, and I'm excited for your contribution going forward in the years to come with the Pankey community. Well, let's go ahead and we'll get started here with our information, if this will advance for us, which it's not. Let's see. There we go. Let me tell you the background of what we're going to talk about tonight. I've been involved in teaching about occlusion and TMD, restorative dentistry and aesthetics for many, many, many years at the Dawson Academy and with Pankey. But about 10 years ago, we were asking the question, so what comes next in dentistry? Where are we going from here? How can we continue to build our profession to be better and better and better? And that's when I was invited by a colleague, John Tucker, to the second ever meeting of a new organization called the American Academy for Oral Systemic Health, or AOSH. And the meeting that year was at the Cleveland Clinic in Cleveland. And so we heard for 2 days, mainly a group of hygienists and dentists, from the researchers at the Cleveland Clinic who were studying every subject you can imagine. And people like Dr. Michael Roizen, who is the medical director, and Dr. Caldwell Esselstyn, who was the chief of surgery at the Cleveland Clinic at one time, began to talk about the healthcare crisis in our country that's going to destroy our nation unless something dramatic happens. They said that one of two options are there for us. One is that we can ration healthcare, which we see happening through insurance, or we can all become rational and start taking responsibility for our own health and learning how to use our lifestyle to manage our health in such a way that we're not dependent on our doctors, but we're dependent on our choices, our good choices, in order to increase our chances of not developing atherosclerosis and not accelerating our aging. And they began to show us through different presentations that it actually is possible through lifestyle to dramatically improve your health and to maintain it for a lifetime. And as we heard these different clinicians talking about how they look at the whole person, not just the symptoms or the chief complaint, not just one test and then a prescription, but actually looking at the background, at the lifestyle, the risk factors that each person may have, and then how they can intercept those through changes, we began to see some remarkable things presented. The challenge has been that medicine as it is today, for the most part in the Western world, is so limited because of the insurance component that most physicians on average spend about 15 minutes every 2 years with their patients. And so Dr. Roizen, in the closing keynote address, he said, you know, we have a healthcare crisis that's destroying our nation, and I want to challenge you as dental professionals to be on the front lines fighting the health crisis that is destroying our nation. And you know, when he said that, I felt like I was receiving my orders for what I should be focused on for the rest of my career and in my work as an educator as well. And so I began to learn everything I could about whole health, cardiovascular disease, about diabetes, about Alzheimer's and dementia, and all of these courses that I went to primarily with other physicians. I was asking, where does dentistry fit in? Is there a role for us? And I began to discover there is a huge role for us. And I would think of oral physician, dentist, hygienist in our teams as primary care providers for complete health, and especially gatekeepers for inflammation, not only locally, such as we see in periodontal disease, but systemically as well. And so we've coined a term that we're calling integrative dental medicine. That is integrative medicine and dentistry where it fits in. So IDM, or integrative dental medicine, is what we're going to talk about tonight. When it comes to the subject of inflammation, that was the thing that we heard over and over and over again from every researcher at the Cleveland Clinic as they were speaking about the future and of their work. And here you see this Mayo Clinic newsletter, and it's entitled Buzzed on Inflammation, the new medical buzzword, something that everybody's talking about, especially talking about how inflammation appears now to play a key role in many, if not most, chronic diseases. Well, as you read that, I hope that you're thinking about what we see every day, because we know inflammation, don't we? We work with inflammation all day long. We look at inflammation all day long. We know what inflammation looks like. It's swollen and red and puffy and bleeds easily and can have a fever. But in periodontal disease, what I want to challenge us to think about is this. When we see tissues like we're looking at this photograph of a mouth, are we thinking, wow, that's a lot of inflammation. I wonder what's going on in the rest of the body. If this is not just a reflection of something much, much, much bigger that can be very destructive in the fact that it can be the key to various chronic diseases. In fact, the chronic diseases that many times our patients who have tissues that look like this show up in our office with. And so types of inflammation and causes of inflammation, we know that there's an oral systemic connection, don't we? And that oral pathogens, which we'll talk about more in a few minutes, can disseminate through inflamed gum tissues into the bloodstream and go throughout the whole body through the vascular system. And so there's that inflammation. There's inflammation that comes systemically from uncontrolled insulin resistance and elevated blood sugar levels that we call diabetes, one of the most serious disorders that you can have in your body. Some have compared diabetes to being like having shards of glass scraping the walls of your arteries all day long. There's almost nothing more inflammatory than uncontrolled diabetes. And then we think about our sad American diet, our standard American diet, and how we have modified the foods that we have been provided in nature, fruits and vegetables and protein. And yet, as we refine carbs, sugars, oils, we modify the chemistry of our food through our cooking processes, such as frying, and we completely change the chemistry, including additives and preservatives and hormones and these sorts of things that actually turn our fuel into fire, and what can be actually a part of our healing of our body into something that actually can create inflammation. Then we know about toxins, especially the toxin nicotine and smoking, and how destructive that can be, and how inflammatory that can be. We also are learning, aren't we, that how we sleep, which is where we spend about a third of our lives in bed, but our sleep quality has a very important factor relative to inflammation, where if our sleep quality is poor, then we actually can initiate an inflammatory process and a cascade of inflammation, a term we'll use a lot tonight, the inflammatory cascade, that can come from the sympathetic dysregulation of turning on the fight or flight response of we're choking to death here, and we release cortisol, stress hormones from the adrenals, and that can chronically cause lots of problems, including cardiac arrhythmias and elevated blood pressure and insulin resistance and a whole host of things. We know that stress itself in our lives can create inflammation, also with the release of cortisol. We know that physical inactivity can be a source of inflammation in our body, as our lymphatics are highly regulated by physical activity. And when we're not physically active, it actually has a very negative effect on the cleansing of toxins from our body and a variety of other functions. And so we see people all around us, don't we, including maybe ourselves, that have sore muscles and sore joints and arthritis, and are taking Advil and Tylenol daily just to keep the pain down. Well, that pain is inflammation. And so we call this inflame aging, as all of these things accelerate aging in a very negative way. There was an article in Time Magazine, a cover of Time Magazine, talking about the secret killer, the surprising link between inflammation, heart attack, cancer, Alzheimer's and other diseases and what you can do about it. I want you to think in your mind, when do you think this article was published? Is what we're talking about tonight new at all to you? Perhaps it isn't, because this article was actually published in 2004. The sad thing is that we have so many scientific facts about what causes our bodies to break down, deteriorate, and the key role of inflammation. And yet we don't really see a whole lot of change in the medical model. Well, we're determined to be part of that change. And we believe that we in dentistry have as good, if not better, opportunity than any other, and I'm going to use the word specialty in medicine, to make these changes. And so let's talk about it. Integrative dental medicine, as we try to simplify this subject so it doesn't sound like we need to go back to medical school in order to be able to implement these things, I've tried to simplify this subject into the least common denominators, and we've come up with 3 key pillars. And these pillars are TMD and occlusion, which is a specialty of dentistry that no one else in medicine is responsible for. So we embrace that as a specialty. Also, airway, breathing, and sleep disorders, and also inflammation and infection. So I want to touch on particularly the last 2 tonight with Laura's help. And the key point that I want to make that we've discovered that's been so helpful in both diagnosis, treatment planning, and actually resolving or solving problems is this: that inflammation, infection, both locally and systemically, TMD, malocclusion, airway, breathing, and sleep disorders are all linked to each other. And the more I observe this and see patients with one problem or the other, the more I see that there really is a linkage there that's very, very common. In the book I wrote, The Shift, basically we go through in great detail the background, the research, and the clinical implementation of this. So that will be your kind of handbook for tonight if you choose to read it. In that book, what we've done is we've tried to make it such that we can standardize how all of us look at this, whether we're in Columbus, Ohio, or St. Petersburg, Florida, or California, or Miami, or Key Biscayne. How can we all be on the same page, looking at this topic the same way, and actually looking at our patients consistently well? And so checklists are a wonderful way to standardize us, isn't it? Aren't they? And so in this checklist, you see at the top, we have the 3 columns that are representative of our 3 pillars. And then as we go down the list, we have history, signs, and symptoms for each one, clinical signs for each one, screening and testing, what would be appropriate considerations for screening and testing if we had positive signs or symptoms. And then on the back page of the checklist, we have treatment options in a very general way. Like, we're going to be talking about periodontal therapy tonight. We have here on the checklist just periodontal protocol. So we may need another checklist perhaps for what our periodontal therapy protocols will be, and Laura has developed those. If you'd like to have the checklist in your hand, you can text Integrative and then go to the address of 22828, and it will send you from that link the checklist. So go to 22828 and text in Integrative, and it'll guide you into receiving the checklist. But on this, if we were to start with airway and breathing disorders, then we will ask our patient in their history certain questions about things that would be red flags. Then we'll look clinically and we'll look for these same red flags. So if we have a patient come in to our office today knowing what we've learned, and they show signs of chemical erosion and abrasion from bruxism, that combination we know is very highly associated, of course, with gastric reflux and stomach acids coming up. But we also know that for many of our patients, that gastric reflux with stomach acids coming up all the way into the mouth is also highly associated with airway obstructions during sleep. And so when we see the example that we have on the top, then in our mind as integrative dental physicians, we're thinking about, is that a red flag for systemic issues such as gastric reflux and such as airway and breathing and sleep disorders? These are things then that we would want to pursue. When we look in the mouth and we see things like a uvula that's partially obstructed, and we see a scalloped tongue, and we see inflammation in the mouth along with signs of acid erosion, then we're really thinking strongly about the fact that there's probably a serious airway type disorder. So you see now how these things are linked. We're looking at a malocclusion. We're looking at destruction of the occlusion. We're seeing acids coming up from a systemic problem called GERD. We're seeing a problem that also relates to airway, breathing, and sleep. And there's lots of inflammation. So that's just one simple example of how we see these coming together. Here's another illustration. This is a 21-year-old patient that came to see us on a TMD referral. And the story that she tells us is that, yes, she has sore muscles in the morning. Yes, she even has headaches frequently in the morning. And she thinks that she might clench or grind her teeth at night. But before she came to see us, 1 week before, she tells us that she woke up in the middle of the night, panicked because her breathing was distressed, and she felt like she was dying. She went to the emergency room. All the tests were negative, and they said, "We think you're having an anxiety attack." They gave her meds for anxiety. What do we see as we simply look as dental professionals in her mouth as she opens wide and lifts her tongue? We see that she has a severe tongue tie. We see she has a scalloped tongue, Mallampati-4, meaning her uvula is down the hatch. She has an omega-shaped upper arch, and she has incisal wear in crossover position on number 6 through 8. All of these are huge red flags for an airway problem. When we did a sleep study on her, her apnea index was at a severe level. And so this is the sort of thing that we see. We can screen and test these things. And in fact, we could send her home and do a home sleep test and find out tonight whether her apnea score is high. A severe apnea hypopnea index score is 30, and she was 32. And so we have a patient coming in for a TMD, quote unquote, problem who actually has a very serious breathing and sleep disorder. This is our report that we can get from our sleep study that was done at home last night, then received back this morning, and then we can talk about that. We see many signs of airway problems from mouth breathing, tongue thrusting, anterior open bites. Bruxism is highly associated with an effort to open the airway, and the teeth happen to be in the way. Oxygen decreases, pH decreases. So we can do home sleep testing to see if there is an inflammatory cascade going on as a result of this poor sleep quality. So you see how we're beginning to expand our model, in a dramatic way. Let me go back one here. We're beginning to expand our model in a very dramatic way. We can manage airway, breathing, and sleep problems with things like CPAP and oral appliances, or today our goal would be, if possible, even to seek to resolve the problem. And so that can be through expanding the oral airway, tongue tie release, nasal breathing, working with anything in the upper airway that may need correction, such as ENT surgery. And we're seeing some remarkable results in patients that have had chronic airway, breathing, and sleep disorders now being reversed, guided through the work that they're receiving in the dental office. Infection and inflammation is a huge subject, and I want to have Laura primarily address this. But as we have patients come in and we ask them questions and we clinically evaluate for signs of inflammation, don't we see so much of this? Indeed, we do. And so as we look at this inflammation, we ask you now that you will, from today forward, ask yourself, I wonder what's going on in the rest of the body. Could there be diabetes? Could there be some other significant systemic problem going on? And so, Laura, let's start talking a little bit about some of the implications of this together. And so we realize that when we have vascular ingress into the system through these oral pathogens, that we can have another inflammatory cascade start in the arteries. And just comment, if you would, on this illustration of the artery and what happens as things break down.
Perfect. I want to take just one little step back to tie in the three pillars. I know I had a comment in there that they're all connected, but I want everyone to just take a moment thinking about that airway and breathing. If somebody's not nasal breathing, we talk a lot about that nitric oxide, but there is also the commonality and link that as you're desaturating, you're moving from aerobic bacteria to anaerobic bacteria. But what's almost more important, that's a huge link with the nitric oxide, is that we're losing our nitrate reducers. So I just want to make that connection, because those nitrate reducers are then in the stomach, permeating through the GI, getting to the bloodstream, and circulating right back into our salivary glands. And how we make saliva is through this bloodstream. But the nitric oxide and these tests here that we see, what you're seeing here is that inflammation in the carotid arteries, in the vascular system, in the coronaries, right? We can talk about this in all these areas. And these are actually some of the tests that are run. The one I want you to kind of focus in on here is this ADMA, that's that dimethylene arginine, the inverse relation to nitric oxide. You'll see it's a very early, what we call player in that process, along with these other inflammatory markers. So I just want everyone to understand how closely that is related. As they're making their way into the vascular system, they are initiating this inflammatory cascade really early on in the process.
And one of the things that Laura's pointing out that is so brilliant is that we now are learning about vascular disease because it relates to oral disease and vice versa. So we want to understand what myeloperoxidase is and what these different tests are for inflammation in the vascular system, because that could be important to us in managing oral health as well. So the question I often ask is, if you were an ophthalmologist, would you be concerned about whether your patient has diabetes? And the answer would be absolutely yes, because you can go blind from diabetes. Well, you can lose your teeth from diabetes as well, but also you can lose your life from diabetes and from atherosclerosis. And so we're going to up our game as primary care providers and begin learning about these things so that we can become educated, informed, and understanding of the ways in which inflammation has a bidirectional effect on our overall health. So this is an article by Dr. Bale and Doneen, a physician and nurse practitioner, and they actually published this wonderful article that basically talks about the fact that from periodontal disease microorganisms, which are listed here, you actually have a bacteremia in the general circulation that can be associated independently with arterial disease. And so they describe in this amazing article in the medical journal that this inflammation and bacteremia can actually start an inflammatory cascade due to these high-risk pathogens coming from the mouth, and that it's a contributory cause of atherosclerosis. And so it's very important that we identify the key bacteria. So Laura, if you would talk about this a little bit and Dr. Neighbor's work.
Absolutely. On that side, the Dr. Bale, Dr. Dunning, and Dr. Vigorous actually were awarded level A evidence for causation in that article, and they named the top 5 bacteria that are responsible for causation. And you're looking at those here. They are AA, PG, TD, TF, and FN. What I think is more profound is that it actually correlates that half of all heart attacks and half of all strokes are actually triggered or caused by these pathogens. So it's important for us to be able to screen for these pathogens, know if these pathogens are present in the mouth, because they are so closely related. You're now going to see more and more research come out that patients who struggle with these top 5 pathogens for 10 years or more. So if you've been in the industry long enough, like myself, I've been a hygienist for over 28 years, you can start thinking about those patients who've really struggled with these conditions. Those patients, 10 years or more, the statistic is 70% will develop Alzheimer's. So it's really understanding that oral is systemic, that they make their way not only through the gum tissue, we have direct penetration through the esophagus, but then also through the GI tract. We're lined from tongue to tail with epithelium, and they are making their way through that epithelium and then into that bloodstream. So these 5 are the ones to look out for. We call them the keystone pathogens. Dr. Tom Neighbors, if you're familiar with him, I call him the father of salivary diagnostics because he brought that technology from Germany here to the United States and started some of our very first saliva tests. So the top 5 here, we're looking at HR5. It is the top 5 high-risk pathogens.
So you'll hear them described in different ways. Red complex, meaning kind of the red hot pathogens that are the most dangerous, both orally and systemically. Keystone pathogens, meaning they're the cornerstone, more or less. It holds the biofilm together in a very pathogenic way and influence the others, as I'll mention here in a moment. And then they're also called the high-risk pathogens. So here's an article in the Journal of Medical Microbiology. And Laura, go ahead and comment on this, and I'll show them this bottom part is just an introduction.
Well, this is really profound research. If you're like me and love the research, you'll see why they're called the keystone pathogens, or what we say, they control the entire oral microbiome. You know, we have somewhere between 17 to 1800 in the oral microbiome. We've named somewhere around 700 to 800 of these species. But what we do understand through the science is that if AA, PG, TF, and TD are there, you see those top 4 there, they actually do something very unique. And you'll hear that they do cellular signaling, quantum sensing, right? Epigenetics, nutrient transfer. But what I want you to see through that quorum sensing, if you're looking at the slide, it's really this middle one that is so profound. They're actually intersecting and exchanging their genetic material, their DNA. So even if you have you tested for the entire oral microbiome, it is these 4 you need to know if they're there. They're pathogenic. And when they exchange that DNA, they're going to make all the rest act pathogenic. So you're always focusing on these top 4. I say they're like the commanders, they're leaders. If you think about, a crowd and somebody's gonna in that crowd, maybe they're participating in something bad and you'd be like, but there's a really good person in that crowd, I can't believe they did that. That's literally what's happening here. Is AAPG, TF, and TD are making then controlling that entire community in the oral microbiome. So it's really important that we always focus on these top 4.
Yeah, it's fascinating to see how that happens, and they're turning an innocent microbiome and biofilm into a mob. And so the effects become significant. So we call those the 5 high-risk pathogens. And there's all sorts of systemic issues that you can see here, basically, that are traveling through the vascular system to all ends of the body to create havoc. And so that's coming from the mouth. Bale and Doneen, in their book, Beat the Heart Attack Gene, describe this in a wonderful illustration of a tree where the fruit of the tree is atherosclerosis, but you see the trunk is what we've been talking about, inflammation. But inflammation is not the root cause. Inflammation is an effect of the root cause being expressed. And so we see root cause coming from things like obstructive sleep apnea. We see root cause coming from things like endodontic lesions and periodontal disease, creating inflammation now that can produce this inflammatory cascade. And so I hope you're getting the picture of the bigger picture. That's what we're really trying to do tonight. So Laura, go ahead and you can talk about this and we'll go right into the next one for you.
Yeah, I think when you're looking at your clinical assessments, right, we're going to tie in those medical assessments. And now this microbial assessment, are these pathogens actually present? And when you look at that, then it's no surprise that 80% of our adult population over the age of 35 have some level of periodontal disease. And this is that microbial assessment that we're talking about, that many patients, even with signs and symptoms or without, actually have these pathogens present. So I think it's just understanding that as you're looking at and you're seeing that inflammation in the tissues, to understand that these top 5 pathogens are anaerobic. So I always say, if we look at that, they're not up on top of the tooth, they're there in that tissue and that vascularity. They're there in that abscess as you look in the middle there at that root canal, and then you're seeing that on this last tooth just invading that bone. They live in the bone, in the tissue, and in that blood supply. So I think it's important to understand then why these statistics are so high as they make their way and are crossing over. Once they get through that epithelium, they're really just repeating this in the bloodstream on all end organs. So think about all your linings. They're going to be able to do this on all epithelium and our endothelium linings throughout the body.
And so the question is, we've got these 5 high-risk pathogens or keystone pathogens or red complex pathogens that we understand are the disease provokers. And so how do we evaluate for those? And that's where this testing has become so invaluable. So Laura, you've been part of developing this, so please comment on it.
Yeah, I'm the Director of Education and Training for Direct Diagnostics. And since these 5 pathogens were named in causation, that's actually why Dr. Neighbors has founded this test, is so you can actually screen your patients. Do they have these top 5 pathogens that not only are putting the mouth at risk, but are they actually putting the rest of the body at risk? So it really then shows you, not only as you look at the test if they have these 5, but you can actually see the levels, what levels they are, so the risk level for the patient. And I always say that testing, is so important because it will guide your treatment decisions. Knowing what's there, then we can make that best treatment decision for that patient.
So we often, in trying to come up with non-surgical periodontal therapy protocols, I know in the past I've been very, very resistant to the idea of using antibiotics to treat what seems like a mouse in the mouth. But actually, as we've been studying, and now as you're getting the picture of the fact that this is no mouse, we're really dealing with an elephant, and the elephant are these 5 pathogens. Then it may be in a good percentage of cases that some type of approach with antibiotics may be appropriate. Now, tell us, if you would, Laura, why amoxicillin, which is the standard antibiotic that's used for pretty much all oral infections, for prophylactic antibiotic use for patients that have had procedures done systemically that we don't want to have infections due to invasive dental procedures. Why is amoxicillin maybe not the first choice always?
Well, amoxicillin is really targeting what we call facultative bacteria and aerobic bacteria. So you're seeing AA there. That is the target there, but it's not touching your other anaerobic species, such as PG, TF, TD, and FN. It actually doesn't lower those at all. In some cases, very, very, unsusceptible to that. So I always say with antibiotics, I always have, the number one rule is, if we're going to put somebody on an antibiotic, let's make sure it's the right one. That's why testing is important, because if the patient doesn't have AA, then we wouldn't be using amoxicillin. We're actually going to go to another choice that's a direct target for those other pathogens, such as metronidazole, or now we even have meloxifloxacin that's in the quinolone family that's actually been deemed safe. I know a lot of people get afraid of that, category of antibiotics, but moxifloxacin, they've done a study on a 10-year study through Medicare, and that's on 65 years or older, and whether they had any tendon ruptures or C. diff, and in 10 years, not one. It's pretty profound study. So we know that there are great antibiotics that we can use that I call our direct targets and have huge susceptibility rates. So again, testing is so important that we're actually choosing the right treatment. I look at antibiotics as not really a controversial. I want everyone to understand if you're in dysbiosis in the mouth, you've lost your healthy common soles, but you swallow 700 to 1,000 times a day. If you're in dysbiosis in the mouth, you're in dysbiosis in the gut. So we have to understand like leaky gums is leaky gut. It's one of the first signs. So we're actually going to be helping our patients by lowering that playing field, not only in the mouth, helping the patient, but also in the gut. And that's a lot of the therapies that we talk about is that if we're going to treat one, we need to treat the other. As airway specialists out there, what I want you to know about PG loves acid reflux. So many times people are saying, I'm taking care of the mouth, but it's bidirectional. It's coming right back and implicated. So again, really helping kind of tying into what we do every day, how important it is to know if you have these pathogens present or not in your treatment.
Yeah, I want to point out that I know we're kind of raising some discussion here that requires a lot more discussion. And so this is just a very, very quick 1 hour overview of a bigger subject and much more detail of discussion that will come later as we're learning together. We do have some options that you may not have been using. If you want to comment on this, Laura.
Sure. I think it's great to know we have categories of treatment, and I like to talk about treatment and then we have maintenance, two separate. So, like what you're explaining is they're kind of giving that overview, but we need to look at all kinds of treatment based on what pathogens are there, we know are more susceptible to different treatments. So, we have trade delivery systems that we can use that are around the tooth that can deliver things such as hydrogen peroxide gel that can target many of these pathogens. We
Mm-hmm.
also have a lot of, antimicrobials, other things that we can use as well. And the biggest piece that we're trying to do is to decrease that load, right? The load that is making its way and really triggering what I say, setting off that inflammatory cascade.
Mm-hmm. And one of the things that we're learning is that not every case is really responsive, for example, to hydrogen peroxide. So we're continuing to learn and develop strategies for something that we're showing you here that has a great use, but it may also be from patient to patient. It's specifically how it would be used and what would be used to deliver something like this. But there have been some remarkable improvements in some patients taking this kind of approach in conjunction with other therapies that we're all familiar with, and including great antimicrobials. We work with very closely with a plant-based company called Stella Life for long-term work with recovery, with pain after surgery, with perio, et cetera. And then Probiora Pro is actually an oral probiotic. It looks like a vitamin C tablet that you dissolve on your tongue and then swish around in your mouth, releasing billions of probiotic bacteria that elevate or raise the pH in competition with those bacteria that we're trying to attack. So we call it sending in the good guy or good troops to run out the bad. So that's another thing that we've seen some really wonderful results with. I'm going to have to skip this, Laura, because of time, but that was a little testimonial from Dr. Bale about the importance of dental health and the dental professionals to work in collaboration with physicians and cardiologists to protect the heart and the whole vascular system. So here you see from the Cleveland Heart Labs a statement that nearly 50% of all heart attacks and strokes occur in patients with normal cholesterol levels. Evidence goes beyond lipids to suggest that inflammation inside the artery walls is the primary contributor and risk for heart attacks and strokes. This inflammation makes the plaque formation soft and vulnerable, much like having a pimple in the wall of the artery that can burst into the lumen and cause the obstruction through clotting that can cause a heart attack or a stroke. So you can have an open artery with inflamed walls that can be a case where you could have a heart attack tomorrow. And that's why inflammation is so important. Laura, would you comment on the inflammatory markers and blood and urine panel?
Yeah, so that's something, we run on the medical side on all our patients. What I really want to sum up mentally is that these five pathogens that we're targeting, they release what's called the lipopolysaccharide. You hear all the time on the dental side this endotoxin. Well, that endotoxin is literally pulling apart the junctions of your epithelium, or in this case, your endothelium. And once those junctions we call uncoupling, when it's in these carotid arteries of the endothelium, they're passing through and collecting in that wall of the artery. That is that inflammatory process that we're talking about. So, we could talk about all of these tests. The top three that I really want to point out here is that ADMA, because you and the SDMA just so closely related to your sleep. It's letting you know that this patient has some type of sleep disorder, and that is contributing to this inflammatory process. And I know we're all highly educated on that, but just to be looking at that, the microalbumin underneath that tells us that is from the kidneys. We know that the kidneys also, these bacteria, when they're crossing over into the lining, I call it the leaky syndrome. We're going to see that leaking through the kidneys, that microalbumin. We know the CRP is just a global inflammatory marker. We have to go find out why this patient is globally inflamed. But these next two have a direct correlation to what you do every day in dentistry. The plaque 2 or PLA2 that you see there has actually been cleared by the FDA as the number one way to know if somebody's about to have an imminent event. And so what I want you to know about that is that it's also closely related to these top five. You provide great periodontal therapy and you reduce these five, you can pull this inflammatory marker plaque 2 down. That is also letting you know that inflammation in that wall of the artery that you're looking at up there. So that's why I want you to know our services, they're really dependent on what you do each and every day dentally. And then this bottom one is MPO, or myeloperoxidase. Again, you'll see that the top has huge implication in the wall of the artery, the inflammation. And this we know when it's over like 470, we need to go find out what's going on. Dr. Bale, that you saw on the screen before that you didn't get to hear from, many times he believes, and he states this out, that he believes 80% of these numbers, when they can't pull down this myeloperoxidase on a patient, they believe that over 80% of them are coming from a silent abscess in the mouth. So highly correlated to the root canals you do, finding those silent abscesses, retreating them. And so I just want you to know how closely related dentistry is to vascular disease and why they're looking at these and really asking to collaborate with us on our side to help be able to pull down all these inflammatory markers that they are trying to help this patient with on a daily basis.
So there's another panel that's called a CIMT, which is a carotid ultrasound, which can show you this softer, more vulnerable plaque if it's present, versus either the absence of plaque or even plaque that's calcified, which really isn't the dangerous plaque as much as the soft plaque. And so you can do a simple ultrasound of the carotid artery and get a good feel for what's going on systemically in that way. Laura, I'm going to have to keep moving just because of time here. So in treatment of infection inflammation, we have these options. Now we have airway, we have oral pathogens that we've talked about. We have vascular plaque that we've talked about. So comment on this, Laura, and just the perspective in your work, working with a cardiologist, working with a nurse practitioner that's has a doctorate in cardiovascular risk, working as a dental hygienist on the cutting edge. Tell us how you see all of this connecting with the inflammatory cascade that we've been talking about.
Well, and that's exactly what I want everyone to process is airway to pathogens to plaque. It is that desaturation, right? We're shifting from aerobic bacteria to anaerobic. These are our pathogens, these top five. It is these top five that can cross over any epithelium or endothelium lining. They make their way into the bloodstream and they are actually then forming those soft plaques in those carotid arteries and even in the coronaries. So this is that connection from airway to pathogens to plaque, understanding that process and then how closely they're connected in this entire inflammatory cascade.
And we want you to see, really, we're looking at this slide and thinking about the future, but we would say that the future has already started. The train has pulled out of the station, and we're wanting to help you see some of the possibilities of things that you could engage in your own practice, at least some of these things, and perhaps in collaboration with another medical colleague on the vascular end. But we want to take a few questions here before we wrap it up, and there have been a few. I'll open the question and answer here, and let's see, Laura. Let's see if we can. Here's a question, Laura, from Tariq Ja says, for the delivery of the antibiotics for periodontal therapy, are you delivering the antibiotics systemically or have a way of delivering the antibiotics locally? If locally, how do you go about doing so?
I'm going to say yes and yes. And that's why testing really helps guide you because we know anything under 10 to the second. So in the hundreds category or even 10 category, literally could count out 10 bacteria. We definitely always want to start in the mouth, right? And even if we're placing then locally an antibiotic. And again, we've created these great treatment guides to kind of help you. I know I'm blurry here, but based on, again, which pathogen, you'll know which one to place, because if it's like a doxycycline, then that's going to work like with your FN. If you need aminocycline, then that's going to target more of your AA and PG. So again, testing is the most important piece. And then that's same true if we have a very high load. So we're talking 10 to the third thousands or higher, we know that that's implicated in the bloodstream. And when that's happening, then we need to look to our systemic antibiotics. When people ask, you saw that slide of the soft plaque, what you have to realize that in those soft plaques, you have AA, PG, and TF at rates of 60 to 80% of those are present in those soft plaques. So we need good dental service to actually make the bacteria platonic so that antibiotics work. And so when we give the systemic antibiotic, again, we need to know it's present as Whit showed you on that slide, and then we're going to pick that best antibiotic. My two rules with antibiotics are pick the right one and then repopulate. We've got to create health. So then we need to repopulate both the mouth and the gut at the same time, an oral probiotic for the mouth and a GI probiotic for the gut. And that's really how we approach that systemically.
Okay, thanks. Here's a question from Vic. It says, acid reflux patients will complain of bad taste in the mouth. Could it be bacteria related? It says, I tell them fluoride rinse. If it's acid etch, can we recommend anything non-prescription? Well, first, let's think, Vic, about the cause of acid reflux. And Stephen also asked, how does GERD cause sleep apnea? So let's address in the subject of GERD and sleep apnea. If you talk to most of our sleep physician colleagues and ask them, do a lot of your patients have acid reflux? They'll say yes. And if you ask why, at least the ones I've talked to will say, well, it's a negative pressure from the stomach up as a result of the effort to breathe through an obstructed airway in the back of the throat. So if you're making an effort to breathe through reflux, but excuse me, through apnea, and you're not able to, you can create a negative pressure in which the acids and gases will come up. And so when we talk about GERD, then we're thinking, could there be a airway sleep disorder problem like sleep apnea? Because that can cause the gastric reflux. The other thing that can cause gastric reflux or acid reflux is an acidic diet. And so there's been a lot of work done on this through gastroenterology and working with patients' diets to be on an alkaline diet. So the two main known or recognized causes of GERD or acid reflux would be an acidic Western diet, in which you would try to change the patient to a more alkaline diet. And secondly, airway obstruction, in which you would want to treat the airway obstruction to address the acid reflux. Could it be bacterial related as far as the bad taste in the mouth? I don't know that. Laura, have you thought about that?
Yeah, that's actually a lot of what Dr. Nathan Bryan talks on, because, digestion starts here in the mouth. So it's really just what you're saying, getting them on a good diet, because I want you to think oral microbiome is so much impacted on healthy commensals. Where are we getting those? Well, nitrates, think about leafy green vegetables, right? Healthy things that we need. And again, that's all interrelated. If we're having a shift there in the oral microbiome to these gram-negative species that we're talking about, right, you're going to get a shift in taste, you're getting a shift in the acidity, right? We're getting a shift, and we're starting to grow these top five. So it's very closely related. But just like you're saying, it's all encircling diet, right? Airway, breathing, the gases. So it's all connected.
Right. Vic asks, any specific probiotic recommendations? Probiotics can be very effective or not very effective. And so there's a couple of things. You want them to make it through the stomach into the gut, if you're talking about for the GI system. The higher count, meaning units, and it comes in the billions of units. So you can get a probiotic that's 1 billion unit. You can get a probiotic that's 100 billion units in concentration. Usually you think of the 30 to 50 billion units as being, a nice, healthy, elevated dose. And then you can have a number of species in that probiotic, and that can range from 1 up to probably 25 or 30. And so you think of 12, 15 or more as being a good species range. In other words, a good population of probiotic bacteria to repopulate in the gut. So we like to think in the range of 30 billion units and about 15 species as being a good probiotic that is digested in the gut. You can go to the health food store and you'll see a whole aisle almost of probiotics. And so the starter would be the number of units and the number of species. Do you want to comment on that further, Laura?
Well, I just want to make the distinction of probiotics for the mouth. It is a little bit different because we're going to target bacteria either fight each other or work together. So again, you need to know what's present. That's what's so powerful about testing. If you have present like AAPG and TD, you're going to need an Oralis, Uberus, or Radius. And there's only one company that makes that product, and that is Probi Pro. If you would happen to have like TF and then FN, you actually need the opposite product, which is a Blish strain, an M18 or K12. And we have lots of great products that have Blish strains. From now you're seeing a new BioGaia come out. You've got Burst, you've got ProDental, right? You've got Pharmaden. So again, you have to know which bacteria is present, because you have to put in then the one that fights that species, because we want to use those fight bacteria with bacteria in that way.
Okay, we've got about 5 more questions and about 5 more minutes. So these are going to be 1 minute each. Frank asks, will you provide a list of all the tests presented tonight and the parameters needed to know when they are out of line?
Well, I'm going to say what they need to come to our course tomorrow because Dr. Gina
Yeah.
Pritchard and myself and you will actually be going through that. We do provide that with those so that you can learn and understand, right, when you have an outlier, when you have this inflammatory marker on your hands that's implicated.
Yeah, we will be, we're doing a course tomorrow separately from Pankey through what's called the IDM Scholar Society. And we're doing a 10-hour course with Laura and Dr. Tom Neighbors and myself and Gina Pritchard, our nurse practitioner. So if you're interested, that's on the IDM Scholar Society, and it's called the Inflammation Infection Workshop. But we also are going to be having a 2-day course I'll show you in a minute at Pankey next August, in which Laura and I will be down at the Institute, and we will spend time going through the results of these salivary tests. In fact, if you come to that course, we will be doing salivary testing on you, and you'll be able to get the results back and we'll look at it. We'll also be doing an overnight home sleep test for you personally while you're there that we can look at the results of. So there's a lot of great personal information that will be provided, as well as learning how to do these tests at that course next August. Let's see, here's Vic is asking, are there any true integrative dental medicine practices under one roof now? Seems like a great win-win business model. Yes, there are some around the country, but Vic, I would tell you there aren't many. You could probably count on both hands how many there are. And so this is just a brand new subject that we're trying to develop. Carol asks Laura, has there been any correlation between these bacteria and other inflammatory diseases such as autoimmune diseases?
Absolutely. You know, we have rheumatoid arthritis, we have celiac disease. You can kind of go on and on down the list, from lupus to almost every inflammatory process. So again, it's just learning that inflammatory process, but we would go in more depth during the course there in August to kind of explain that process, but absolutely huge connection.
Okay. Another question, Tariq says, after delivery of antibiotics with or without periodontal therapy, do you do follow-up salivary testing to help with measuring success?
Yes, but I'm going to caution everyone. I want you to think for a moment. If antibiotics just got rid of periodontal disease, why do we have periodontal disease? We have MDs across the nation who are more than willing to write for antibiotics. So there's a very important step in there. We'll go into that in depth, but they need your dental service for the antibiotic to work. Huge, huge, huge connection. That's why this is so, I say, like cutting edge, and you'll hear my passion. We need all of us as dentists and our service to actually make these antibiotics and some of these other processes, the pathways, actually be able to work in the systemic system.
Mm-hmm. Here's an anonymous question of how can I incorporate salivary testing in the office? Is it a covered dental benefit?
They're working on that. We do have codes, but you'll find that they're not always covered. Again, that's like anything else in dentistry, right? But there are dental codes. They're working on it on the medical side. So again, I think, you know, like anything, it takes time. But right now, the average fee, retail fee that people are charging their patients through HR5 is $99. So through our company, Direct Diagnostics, to you can range anywhere from $68 down to $57. So Dr. Newers has worked really hard on making it affordable for our communities.
As far as incorporating this into your practice, I would say for now, without any training, you could go to Direct Diagnostics website, and Laura has some videos and some different aids available there that you could see that would help you get a better feel for how you can get started. Okay, 3 more questions and we're going home. Frank asks, once the tests are brought down to acceptable levels, how do you maintain it and how long does it last?
Great question. So that's really what we'll work hard in the course, is understanding what is treatment and what is maintenance. I love Dr. Hyman's whole philosophy on we have to focus on creating health. And that's truly what phase two is about. Phase one is about treatment. And I do think that we need to really spend a lot of time on phase two, which what is true maintenance so that we don't have recurrent periodontal. We can show through our studies, we can maintain health. We've got to create it and then help our patients be able to maintain that. So stay tuned. There is definitely a way to do that.
Okay. Stephen asks, are you suggesting that the apnea causes GERD? Yes, we are suggesting that apnea can cause GERD through the negative pressure and obstruction of the airway. I've talked to a number of sleep physicians who this is all they work with, and they feel very strongly that that's true, that apnea can cause GERD, and GERD can cause cancer of the esophagus, and that it very well could start with airway breathing disordered sleep. Chris Duval, our very, 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 very dear friend, asks, do you recommend the probiotic at the same time as the antibiotic? Seems to me it would be better after the antibiotic.
That is there's a lot of controversy on that. We have to remember that even just timing, there's a lot of studies on just waiting 30 minutes to, we know, like, Florastor, which actually is a yeast, that is deemed as a probiotic, and no antibiotic actually even touches it. So it depends again what probiotic we're putting the patient on, but there are lots of great probiotics and postbiotics that aren't even touched by these antibiotics.
Thank you, Laura, for being with us tonight. I know you all are impressed with the knowledge that you've learned from her, and I can promise you we've only scratched the surface. And thank you all for being with us tonight and being so patient. We've had a great crowd. I want to invite you to sign up, and if we do this in Masters Hall, I think it's going to be filled after tonight. But if you would go ahead and join us down at the Institute in Key Biscayne, August 11th next year, we're going to have 2 full days of training and learning and workshop on this subject of integrative dental medicine. And we look forward to being with you in person there. Meanwhile, below are our email addresses. And so if you have more discussion that you'd like to have with us, please email us and we'll be happy to converse with you further in any way that we can help you. So I think we'll wrap it up for tonight. Thank you, Laura, so much for being with us, and thank you all for your kind attention. It's great to be together, and we look forward to being together in person soon. So have a good evening and a good weekend, everybody. Take care.